Hi, I'm Dr. Sumbul Beg, and this is Easy Endo Prep, Endo in a Bite. Your go-to no-fluff podcast, the perfect study snack for busy endocrinologists who want fast, board-relevant content that actually sticks. You can grab the full board review course at easyendoprep.com. Today, I'd like to talk about a topic that's become increasingly relevant in cardiovascular and endocrine risk assessment: lipoprotein A. We'll discuss the atherothrombotic risk associated with elevated lipoprotein A, the clinical indications for measuring it, the mechanistic underpinnings, and where the field is headed in terms of therapeutic options. This is a molecule with unique behavior, genetically determined, relatively stable throughout life, and an independent contributor to cardiovascular morbidity. Elevated LPA levels are tightly associated with a range of atherosclerotic cardiovascular conditions, including myocardial infarction, ischemic stroke, and peripheral artery disease. In addition, aortic valve stenosis has been increasingly linked to elevated LPA due to its role in both valvular calcification and inflammation. The mechanisms through which LPA promotes vascular injury are multifaceted. Atherogenesis is accelerated through its LDL-like core, which promotes lipid deposition in arterial walls. It's prothrombotic, thus inhibiting fibrinolysis and promoting thrombus formation. And it's pro-inflammatory because LPA carries oxidized phospholipids, which induce endothelial dysfunction, vascular inflammation, and downstream damage. There's no defined lower threshold below which LPA is considered risk-free. In other words, the cardiovascular risk rises proportionally with LPA concentration. The key takeaway is that LPA isn't just a passive lipid particle, it's biologically active, interfering with fibrinolysis, amplifying oxidative stress and facilitating both thrombosis and plaque formation. Now, turning to testing indications, when should we actually order an LPA level? The most important thing to remember is test once and test wisely. LPA is genetically determined and exhibits minimal intra-individual variation over time, so a single lifetime measurement is typically sufficient. That said, we don't recommend routine screening in the general population. Instead, targeted testing is recommended, particularly in individuals where traditional risk factors don't fully explain the clinical picture. Who should be screened for LPA? One-time LPA measurement is recommended for the following groups: premature ASCVD in patients or first-degree relatives, men less than 55 years, women less than 65 years. That's what counts as premature. Familial hypercholesterolemia or suspected familial hypercholesterolemia, recurrent or progressive ASCVD despite statin or LDL-lowering therapy, severe hypercholesterolemia, for example, LDL-C equal or more than 190, and this is to assess risk modifier, calcific aortic valve stenosis, particularly if premature or unexplained, ischemic stroke without clear cause, especially in younger adults, intermediate risk patients where risk stratification may guide therapy decisions, family history of elevated LPA, and South Asian ancestry or African descent. This is where we see higher baseline LPA levels. Now, as mentioned, LPA is generally not repeated because it is genetically determined and stable throughout life. Thresholds of concern: LPA equal or more than 50. That is associated with a 2 to 3 times higher ASCVD risk. LPA equal or more than 180 milligram per deciliter. This suggests risk similar to heterozygous familial hypercholesterolemia. Now remember, risk increases are continuous. There's no absolute cutoff. Consider LPA as a risk-enhancing factor on a spectrum. Now remember, statins do not lower LPA and may slightly raise it, but it's still recommended. Niacin lowers LPA modestly but is not routinely recommended due to lack of outcome benefit. PCSK9 inhibitors reduce LPA by around 25%, with some ASCVD event reduction tied to that. And LPA-targeted therapies, Olpasiran, Pelacarsen, these are in clinical trials. Let's talk logistics for a moment. Fasting is not required, making this test convenient to incorporate during routine lipid panels, and importantly, due to low biologic variability, a single measurement is sufficient in most cases. Now let's look at the evidence supporting LPA as a bona fide risk factor. We have strong genetic and epidemiologic evidence from Mendelian randomization studies linking elevated LPA to causal pathways in ASCVD. This isn't just association, it's causal inference. Critically, LPA elevates risk independently of LDL-C, HDL-C, and other traditional lipoproteins. It operates on its own axis. In patients with other coexisting risk factors, such as hypertension, diabetes, or metabolic syndrome, the effect of LPA is additive, compounding overall cardiovascular risk. And this isn't fringe knowledge. Major cardiology and lipid societies now recognize LPA as a risk-enhancing factor in formal guidelines. At this time, we have no FDA-approved therapies that specifically target LPA reduction. Let's wrap up with what you need to know for the boards. Who should get one-time LPA measurement? Start with anyone who has had premature ASCVD. That means MI, stroke, revascularization in men under 55, women under 65. And that includes first-degree relatives too. Next, think about familial hypercholesterolemia. Anyone with known or suspected FH should have LPA checked. If someone has recurrent or progressive ASCVD, despite being on statins or LDL-lowering therapy, you have to think of LPA as a hidden risk. Don't forget LDL-C over 190. Here, LPA acts as a risk modifier and may change your management. Then we have calcific aortic valve stenosis, especially if it's early onset or unexplained. LPA is a known contributor to valve calcification. And don't forget ischemic stroke without clear cause, especially in younger adults. That's another flag to check LPA. And then I've seen many board review questions where they present a patient in the immediate risk zone, where the ASCVD risk calculator is 5% to 20%. LPA testing can help tip the balance. And of course, family history of elevated LPA. That's a straightforward yes, test them. Finally, pay attention to race. South Asian and African descent populations tend to have a higher baseline LPA, so a one-time check makes sense. Bottom line for the boards, LPA is genetically determined, doesn't fluctuate much, and one-time screening in the right patient can be game-changing. And that's it for today's bite-sized episode. A quick focus review on who should get screened for LPA and why it matters. And if you've signed up for our newsletter over at easyendoprep.com, we'll send you a direct link to the PDF. The actual show notes for this episode also include a few more key details, things that didn't quite make it into the audio but are still worth knowing. Specifically, I included my notes from the ACE meeting in Orlando 2025 on LPA. It was a very nice lecture, and I have included them as an addendum with the show notes. Thanks for tuning in to Easy Endo Preps, Endo in a Bite. I take the most relevant points for the endocrine boards and chunk them down into bite-sized pieces of knowledge. Until next time, stay curious, stay consistent, chunk it down, and keep it bite-sized.